Dr. Frank and Dr. Chen and our team, Dr. Hamadani, were really good at creating iatrogenic problems. And one of the major iatrogenic problems is the profound immunosuppression that come along with allogeneic transplant and CAR T-cell therapy, as you just heard. And so we need people who can help us tackle those iatrogenic problems, and our next speaker is working on just that. That's Dr. Danniel Zamora, who is Clinical Assistant Professor, Division of Allergy and Infectious Diseases at University of Washington School of Medicine, and works with the Fred Hutchinson Cancer Research Center in Seattle. He completed a residency at UT Southwestern, followed by a fellowship in infectious disease at UT Southwestern as well. And I've mentioned his current role at the University of Washington, and he is focusing a good deal of his research efforts on how we can best deal with cytomegalovirus. And I just want to point out before he comes up here, I think the first report that I remember seeing from Stan Riddell's lab was in 1993 in the New England Journal of Medicine on CMV-specific CTLs. We know that they work, and now it's many, many years later, and we still don't have a commercialized construct. We're still dependent on ganciclovir foscarnet to deal with things after the fact, letermovir up front to try to prevent CMV infection and disease. But CMV continues to be the bane of our infectious disease existence, and most importantly for our patients, all these years later, in addition to community-acquired respiratory viruses. So we're glad you're here to help us solve these problems we create.
Okay. Excuse me. Thank you so much for that introduction, and I'd like to start by thanking the organizing committee for the invitation to speak with you. I'm going to have to probably breeze through a couple of slides to catch up a little bit in terms of being on time, but let's get right to it. So talking about CMV in the context of transplant and CAR T. This is just kind of an outline. We can just kind of skip through that, but so we'll start with CMV infection and disease after transplantation. So a little bit of background and kind of the basics, right? So CMV has actually historically been known or referred to as the troll of transplantation. It's a human beta herpes virus that infects approximately half of us by the time we reach adulthood. And like other herpes viruses, it has the potential to, after primary infection, become latently infected and essentially in periods of stress on the body in terms of immunosuppression, et cetera, has the potential to reactivate from various sanctuary sites. So now the clinical manifestations of CMV infection are widespread, but they are much more severe and encompass end organ disease, specifically in immunocompromised patients such as transplant patients. The highest risk in transplantation is those that are CMV seropositive, as we all know, and other risk factors to consider in terms of CMV risk stratification are, they include the specifics on the donor in terms of HLA matching, whether or not a cord blood donor stem cell source was used, whether T-cell depletion was also used prior to transplant, and also depending on the immunosuppression used for graft versus host disease in terms of prophylaxis and for treatment, which is largely revolving around steroids. So I'll start a little bit about kind of newer kind of developments in our knowledge in terms of CMV risks after transplantation. Now, this is a slide that is depicting data from our center at the Fred Hutch, where we looked at various CMV viral kinetics with different GVHD prophylaxis regimens, and what was seen and what has been actually corroborated with other studies, even in larger studies such as in the CIBMTR by Goldsmith et al. We know that post-transplantation cyclophosphamide for GVHD prophylaxis is actually associated with an increased risk of CMV reactivation. And as you can see here in the green line, that's primarily evident in the early phases after transplant, and then kind of levels out later on. But and the reference there in the red is methotrexate. Now, in terms of other newer GVHD prophylaxis regimens, So we talk about sirolimus and sirolimus-based GVHD prophylaxis, and what we see is that sirolimus actually is associated with a decreased risk of CMV reactivation. So it's something that's kind of exciting, and then I don't even touch upon this in the talk, but there's been more recent studies that have shown that there is potentially a synergistic effect with sirolimus and letermovir prophylaxis in terms of antiviral effect. So that's something exciting, and I think that's still being actively investigated at this time. So not going to spend too much time on this, but just broadly, there are two broad CMV management strategies after transplantation. The first is what we know as preemptive therapy, and that's when we actually use CMV DNA PCR surveillance after transplantation, and at a point thereafter, after transplantation, CMV reactivates, and depending on a specific threshold, which is usually institution-specific, then you start antiviral therapy. On the other hand, we have prophylaxis, which is where you give a preventative antiviral, and some centers use CMV DNA PCR surveillance in parallel to giving prophylaxis. But again, largely, if you do experience clinically significant CMV during prophylaxis, then you start actual treatment antiviral therapy. And so the more recent kind of developments in the prophylaxis realm have been looking at the potential extension of letermovir prophylaxis from 3 months after transplantation up to 6 months. And I'll get into a little bit about what studies have shown in terms of that. Okay. And so I wanted to also have this caveat placed here that preemptive antiviral initiation thresholds are not universal across transplantation centers, but largely, and I know that this is a survey from Europe, but I think it still kind of holds true here in the U.S. where that a lot of centers use around a threshold of primarily in 1,000 IUs per mil to decide whether or not to initiate preemptive antiviral therapy. And as you can see, as you get higher and higher in those viral loads, less centers are actually comfortable with using those higher thresholds, which makes sense. I think that's just kind of leads into the fact that higher CMV viral loads can lead to potentially development of CMV disease. Okay, let's talk a little bit about antiviral therapies for CMV treatment and prevention. So historically, or traditionally, what we've had in our armamentarium included ganciclovir and cidofovir, which both inhibit CMV DNA polymerase at UL54. Ganciclovir specifically requires an additional phosphorylation event by UL97. And I only bring these things up because, and I don't go into this in the talk, but these things become important in terms of the development of resistance after transplantation, so that you can already see that if you have resistance in some of these specific proteins, then it doesn't necessarily preclude the using another antiviral as long as it's kind of in a different pathway. We also have foscarnet that's been used that also inhibits DNA polymerase. But the use of these antivirals has been largely limited by cytotoxicities and nephrotoxicities, especially in the context of prophylaxis. So this is why, again, historically, we had been using more so preemptive antiviral therapy. And then newer to the block, we have letermovir and maribavir with the former, which inhibits CMV terminase, which is important for cleaving DNA into concatemers for CMV, and maribavir inhibits UL97, which is important for viral egress. Now, what's more important about these newer antivirals is that fortunately, they've actually been associated with less adverse side effects. I think the most common that we see with both letermovir and maribavir are primarily gastrointestinal upset. So this isn't new data, right? This is data showing the results of the phase 3 RCT looking at letermovir prophylaxis for the prevention of clinically significant CMV in the first 100 days post-transplant. The study was spearheaded by the late Francisco Marti, and as you can see on the left that the letermovir was associated with decreased clinically significant CMV infection, but at the same time, after letermovir is actually removed from the equation, you can actually see that there is a bump or a rebound effect in terms of CMV reactivation events that take place. So that's important in terms of future studies that kind of beg the question of, well, what if we kick the can down the road a little bit and extend prophylaxis? Now, the phase 3 study has also been supported by a number of single-center studies, and this is on the right, a meta-analysis that showed that essentially the same, that letermovir works in terms of preventing clinically significant CMV infection. Now, despite preventing clinically significant CMV infection after transplantation, we still see a CMV disease rate of about approximately 1% in the first 100 days. Now, this is also kind of an interesting aspect of letermovir, and I think more data should potentially needs to be kind of devoted into kind of looking at these non-infectious outcomes that may be associated with some of the antivirals we use. So letermovir prophylaxis specifically has been associated with improved mortality outcomes after transplantation. And as you can see on the left, that's both in terms of non-relapse mortality, and on the right, overall mortality. And again, these come from a meta-analysis that was performed. So let's talk about late clinically significant CMV infection and prevention. So what I mean by that is, and what historically has been meant by that is looking at CMV infection events after day 100 post-transplantation. Now, this is data from a study that from our center that was a large study of about almost 2,500 patients that spanned the two different eras, right? The preemptive antiviral therapy there at the Fred Hutch, and then also reflecting the letermovir when we rolled out letermovir prophylaxis institutionally at around 2018. And as you can see on the left, the rates of CMV disease in the era of preemptive antiviral therapy and letermovir prophylaxis, they do differ. There is less in the letermovir prophylaxis era. But what was also seen is that there is less disease later on after transplantation, and there's differences actually, this is kind of super interesting, in the different organ manifestations of CMV disease within the two eras. So as you can see on the left, in the preemptive antiviral therapy era, there was largely dominated by CMV pneumonia, which fortunately we don't see much of these days. It's very devastating, and it's really difficult to treat, and we scramble and look for interesting ways to kind of combat this, including IVIG. But on the right, as you can see, more common these days in the era of letermovir prophylaxis is CMV GI disease. Now, in terms of risk factors for these different end organ disease manifestations, they're largely driven by actually preceding CMV reactivation in the first 100 days post-transplant and the use of corticosteroids. But interestingly, we did see some signals for an increased risk of CMV GI disease in patients who received post-transplantation cyclophosphamide. So that's something that should deserve some more exploration as well. So then this is what I was referring to in a couple of slides previously in terms of are we kicking the can down the road, so to speak. So this is actually data from another phase 3 that looked at what happens if we extend the duration of letermovir prophylaxis up to 200 days post-transplant. And it makes sense that we do see a decrease in clinically significant CMV infection up to day 200. But as you can see highlighted on the left in the yellow circle, that there is, again, another rebound effect that we do see after withdrawing the prophylaxis. And on the right, we actually do see that there might be a signal for a decrease in mortality in patients who receive extended duration letermovir prophylaxis. Now, I'm part of the committee that is updating the guidelines for AlloSCT in terms of CMV prevention and management. And at this point, we are going to recommend in the higher risk patients that extension to 200 days is potentially warranted. But that's actually going to be published potentially in the next 1 to 2 months, actually. Now, this was an interesting study that showed that extending duration of letermovir prophylaxis after transplantation may actually decrease hospitalization costs compared to using preemptive antiviral therapy. And in the blue bars, you can see that the respective costs associated with letermovir versus in orange, the preemptive therapy era. And it's quite striking, that there is a decrease in both inpatient and outpatient cost in patients who receive this extended duration letermovir prophylaxis. Now, in talking about differences in pediatric versus adult transplantation, there is differences in terms of the different age ranges and how patients actually reactivate CMV after transplant as well. We do see less CMV reactivation in younger pediatric patients, and when I say younger, as you can see in the blue line, we're talking about ages 0 to 10, compared to kind of the more adolescent and adults in the blue and green. We do see less CMV disease organ manifestation in children as well. But kind of interestingly, we do see that the CMV disease that we do see in children is actually driven by CMV pneumonia compared to adults, which we, again, primarily see CMV GI disease. Now, more recently, I believe at the tail end of last year, letermovir has been FDA approved for pediatric CMV seropositive transplantation in terms of prophylaxis. So let's talk about CMV infection in other populations. I had initially said, labeled this slide as special populations, but I think that's, I think other is probably a better term. So we'll talk a little bit first about refractory and resistant CMV infection. What do I mean by refractory and resistant CMV infection? Well, there's actually updated consensus definitions as of 2024 of what that actually means. So in terms of refractory CMV infection, we refer to that as a CMV DNA anemia that increases or persists after at least 2 weeks of antiviral therapy. In terms of CMV disease, it's kind of a similar concept, but it's also driven partially by worsening of symptoms or signs and symptoms, or progression to disease, or lack of improvement of signs or symptoms after 2 weeks of antiviral therapy. In terms of resistant CMV infection, well, that's basically what we refer to as refractory CMV infection, in addition to actual genetic mutation evidence that increases or decreases susceptibility to at least one antiviral. Now, which kind of brings me to, this is data from a phase 3 study that was done looking at maribavir for the treatment of resistant and refractory CMV infection. Actually, this study in particular looked at maribavir versus what was designated as investigator-assigned therapy, which could have been anything from valganciclovir to ganciclovir and foscarnet. All the other antivirals that we typically potentially use for CMV reactivation. And what we saw is that that maribavir works in terms of treatment of refractory and resistant CMV infection. And there was a significant proportion, a significantly increased proportion of patients who received maribavir had more CMV viremia clearance at the end of week 8 of therapy. Now, I will say that after the results of this study, that the FDA had also approved maribavir specifically for the use in refractory and resistant CMV infection. So that was another tool that fortunately we were able to add to our armamentarium. So in terms of safety signals, I kind of alluded to this in one of the earlier slides that maribavir is pretty well tolerated. We don't see much in the way of cytopenias or renal toxicity. But again, the things that we do mainly see are kind of GI effects, including dysgeusia. What about using maribavir in terms of preemptive therapy after transplantation? Well, there was a recent study that was published last year that a multi-center randomized double-blind phase 3 trial, it's referred to as the Aurora trial, which enrolled patients that had first asymptomatic CMV infection and to receive either maribavir or valganciclovir, and the primary endpoint for the study was CMV DNA EMEA clearance at week 8. And what was seen at the end of this study was that maribavir ended up being non-inferior to valganciclovir for the primary endpoint. So at the moment, maribavir is not currently used or approved as first-line therapy for preemptive antiviral therapy. Well, let's talk about CMV in the context of CAR T-cell therapy. Now, and this ends up being a bit of a hot topic issue because we are still kind of scratching our heads of what to do in these patients. But altogether, studies have shown that the risk or the incidence of CMV after CAR T is about 20 to 30%. Some of the risk factors in CAR T patients in particular include patients who receive BCMA CAR T cell therapy, as well as the use of corticosteroids for CRS. Now, CMV disease in CAR T cell therapy recipients is actually very rare. But based off a number of these kind of single center studies, it would be okay to consider surveillance in high-risk patients who receive CAR T cell therapy for at least 2 to 6 weeks after cell infusion. There's not much data to back this in terms of randomized trials or anything like this. Again, it's largely driven by observational data. But that, and then afterward, I think antiviral therapy based off of a specific threshold may be considered on a case-by-case basis. But right now, as it stands, prophylaxis is not recommended. And so these last 3 points I'll point out that are points that we are actually going to include in our ASTCT guidelines. So I didn't include any actual grading recommendations because those are still kind of in flux. This is another study kind of showing the incidence and outcomes of CMV after CAR T. And again, it shows on the top left about a 30% incidence of CMV reactivation in patients who receive CAR T cell therapy. In terms of patients in panel B and panel C on the left side, you can see that patients who actually have higher grade CRS or use corticosteroids, and there's going to be a lot of overlap there, but those two subpopulations actually experience relatively more CMV reactivation than patients who have lower grade CRS or don't receive corticosteroids. And there are signals to say that patients who do experience CMV infection after CAR T cell therapy may actually have worse outcomes in terms of mortality, but I think this is actually another area that needs to be that needs more data as well. Now, in terms of antiviral combination therapy, sometimes, and I'll start this part of the talk with a caveat that if this is ever being considered, I think you should be kind of thinking in conjunction of potentially in the context of a consult with an infectious disease specialist. But there are some possible advantages in terms of improved viral clearance and symptom resolution. The application is kind of clinically complicated, and this is again is why I allude to the fact that you may be wanting to talk to an infectious disease specialist kind of before doing any kind of combination therapy. But there is evidence to suggest that it does work, at least for other viruses, and there has been some studies that show specifically that there may be some additive effect, if you will, for maribavir and letermovir in the use for use in combination therapy. There is also data to suggest that maribavir and ganciclovir are antagonistic, so that this is a specific point that we'll also be including in our updated guidelines to say that don't do that. Don't use maribavir and ganciclovir at the same time, because there's a potential for antagonism. And just as I alluded to with the sirolimus and letermovir data, there is potential synergistic effects with sirolimus and maribavir, so that's kind of an exciting area that needs to be explored further. So this last part of the talk, actually, I wanted to, this is actually the most exciting part of the talk for me, at least, is how do we get better at treating CMV infection, or at predicting who will develop CMV infection after transplantation? And I think there's been some interesting developments. So this is a little bit of background for a study that we did, but so it's been noted that pre-transplant CMV disease is associated with an increased risk of post-transplantation CMV disease and mortality after transplantation. But what about CMV reactivation in the context of CMV DNA PCR surveillance prior to transplantation? So this is a little bit of background. So in 2010, our institution actually began routine pre-transplant CMV DNA PCR testing at least 2 weeks prior to transplant, and what we saw was that it's not uncommon. Actually, CMV is detected in 11% of seropositive recipients prior to transplantation. And this is a study that we conducted, again, it spanned multiple eras at the Fred Hutch. On the left, we have patients that were from the preemptive antiviral therapy era at the Fred Hutch. And on the right, you'll see that patients from the letermovir era. And interestingly enough, the CMV detection rate was the same for both eras. So, and this was based off of a large cohort of patients. We're talking about almost 1,600 patients who were tested prior to transplantation. So we asked that same question. So what does that mean in terms of post-transplantation outcomes? So pre-transplant CMV reactivation is actually, we noted, increases the risk of post-transplant CMV reactivation. As you can see on the left, these are patients who are stratified by whether or not CMV was detected prior to transplantation. And you can see in the red line that for patients who had pre-transplant CMV reactivation, that they did have a higher incidence of post-transplantation CMV reactivation, at least up to 100 days post-transplant. But interestingly enough, we did also look at how this affects outcomes in terms of CMV disease. And patients with pre-transplant CMV reactivation were also seen to have higher risk of post-transplant CMV disease up to a year post-transplant. Now, that begs the question, so if pre-transplantation CMV reactivation is associated with a higher risk of post-transplant CMV reactivation, well, what happens if you get rid of it, right? What if you treat the pre-transplant CMV reactivation prior to going into transplantation? And so we looked at patients kind of stratified by whether or not they actually cleared their CMV DNA-emia prior to going into transplantation. And we have 3 different stratifications here that you can see, or strata that you can see here. We have patients who had a positive CMV test in the green, but and actually continued to be positive leading into transplant. In the red, these are patients that were previously positive but turned negative within 30 days, primarily with the use of antiviral therapy. There were some patients who kind of spontaneously resolve as well in terms of their viremia. And then in the blue, we have patients that didn't have any pre-transplant CMV. And as you can see, that patients who cleared their viremia, those patients in the red line, had a reduced incidence of post-transplantation CMV compared to those who went into transplant with CMV. So in the context of this study and in our center, we actually, and there's not much, this isn't driven by much data in terms of our threshold, but we do give antiviral therapy pre-transplant antiviral therapy for CMV DNA detected greater than or equal to 50 IUs per mil. And if patients actually have a positive test prior to transplant that kind of straddles that threshold, we do recommend a repeat test, and this is where we kind of sort out who is actually spontaneously clearing versus not. So that was data primarily on in the last slide from patients in the preemptive antiviral therapy era at our center. So looking at patients in the letermovir prophylaxis era, we actually see the same effect that post-transplantation CMV reactivation, that the pre-transplant CMV reactivation risk associated with, the association with an increased risk of post-transplant CMV reactivation is still important in the era of letermovir. So I think it's something to consider in terms of centers for patients who, in terms of kind of institutional guidelines, whether or not you want to actually, in addition to doing kind of standard serology to figure out who is high risk and seropositive, whether or not they are actually actively reactivating CMV prior to transplantation. So switching gears a little bit to immunology. So there's been some recent data, and this is kind of interesting, to suggest that high pre-transplant anti-CMV IgG titers are actually associated with an increased risk of post-transplant CMV infection. And what's interesting about it is that this is data that, again, is barely kind of rolling out since over the past 2 years, where we've actually had these IgG quantitative assays kind of for decades now, and we're only kind of stumbling upon this kind of this phenomenon again. So this is data from a study of 440 patients who had pre-transplant CMV serologic testing. And multiple donor CMV serotypes were actually included in this study, but patients were stratified by the level of their anti-CMV IgG titers. So we had those with the highest levels in Group A and those with the lowest at Group C. And the different bars that you see on the right there are looking at patients who had, the darker bars are those that had clinically significant CMV infection, with the kind of the lighter shaded gray being no infection, and those in between are just some clinical reactivation events. And so you can see that proportionately, those in Group A who have the higher anti-CMV IgG titers have higher proportional clinically significant CMV infection, and that's actually been seen in other serologic studies. But we actually we took it a step further in our own, in our lab, where we looked at CMV serologic seropositivity at the epitope level using this very fascinating VIR-scan technology, which is essentially based off of FIP-seq technology, where we engineer a phage library, we add patient serum, and we can basically test against patients' serum and find out what specific viruses a patient has been exposed to over the course of their life, but also kind of do a further deeper dive into the epitope level of each of these virus antibody levels. And we talk about with the VIR-scan this technology. We look at total hits per organism, meaning, again, the amount of unique peptide epitopes that had bound antibodies. But on the right, we also can talk a little bit about what we refer to as an epitope binding signal, which is essentially the it's a quantitative representation of the amount of antibody detected to each specific peptide. So for all intents and purposes, you can kind of refer to it as an antibody abundance. And this is actually data that was presented at EBMT in 2024, where we saw patients that, again, similar to what was seen with standard serology, patients with lower, backtrack here. Patients with higher CMV antibodies at the epitope level were actually at higher risk for post-transplant CMV reactivation. And this is stratified by the quartile distribution. You can see that there's a bit of a grouping between the second through fourth quartiles, with the first quartile essentially being relatively protected compared to the other quartiles. And we saw the same with that antibody abundance metric as well, which again is further kind of support to the fact that patients with higher CMV antibody titers have a higher risk of post-transplant CMV. Now, it might beg the question of why? Why would that be? And I think that's a great question. And one of our leading hypotheses is that it may be that serology prior to transplant is actually reflective of the overall infectious burden that a patient has going into transplant, so that those with higher patients with higher titers have a higher burden of CMV altogether. But that remains to be actually seen. So let's switch gears a little bit from antibodies to cell-mediated immunity. So this is just kind of a schema of different assays that can be used to quantitate CMV-specific cell-mediated immunity. And I wanted to focus a little bit more on this AlloSCT technology, but suffice it to say that there's a lot of things that are available in terms of measuring CMV specific cellular immunity. And I think finding something that is kind of easy to use, something that is easily translatable to the bedside, as opposed to sending a patient sample for intracellular cytokine staining, is probably it's more attractive in terms of putting it into clinical application. So this is data from a study that was done that looked at CMV, CMI, and CMV infection after transplantation using this T-spot technology. And what was seen is that CMV, cell-mediated immunity against both two different antigens, CMV antigens, IE1 and PP65, was decreased in patients who eventually developed clinically significant CMV infection. Now, there's limited data of using these types of bench to bedside kind of technologies in the era of letermovir. So because of that, we actually performed a study at our center, and this is data that is actually, I think, should be published actually within any day now, and potentially next week actually in BMT, that we looked at can we characterize post-transplant CMV cell-mediated immunity following the use of short-term meaning in the first 3 months, letermovir prophylaxis. And our hypothesis going in was that patients who received letermovir prophylaxis actually had a relative decrease in their CMV cell-mediated immunity compared to those that didn't. We had a limited kind of preemptive antiviral therapy control cohort that we were making that assumption based off of, and that's actually data that we've seen using intracellular cytokine staining too. But the more exciting aspect of the study was asking this question about whether higher CMV cell-mediated immunity was associated with decreased incidence of late clinically significant CMV infection. And so what we saw is actually that seems to be the case. So CMV, CMI is actually decreased in patients who develop late clinically significant CMV infection, and that is true with respect to both PP65 and IE1, again, these are two different unique CMV peptides that are routinely tested in terms of cell-mediated immunity. And as you can see, for IE1, the difference was actually much more significant. Now we looked at the cumulative incidence of late CMV infection stratified by whether or not a patient had high CMV CMI versus low CMV CMI. And I didn't include the data, but we actually performed an RRC analysis to define thresholds for what is high, what is low, and so that in terms of protection, that patients with PP65 CMV CMI greater than or equal to 67 spots, or IE1 CMV CMI greater than or equal to 4 spots, those were considered as having high CMV CMI. So altogether, patients who had high CMV CMI to both PP65 and IE1 had a decreased incidence of clinically significant CMV infection up to 200 days post-transplant, which was kind of exciting. So what is kind of shaping the immune system in these patients in terms of these different antigens? So it seems to be largely driven by the stem cell source, with peripheral blood stem cell source actually improving CMV cell-mediated immunity. Patients who have CMV seropositive donors also have the tendency to have higher CMV CMI. And patients with subclinical CMV reactivation or reactivation at multiple levels in the first 100 days post-transplant also develop higher levels of CMV CMI. So how do we kind of make that work better? As you can see, the difference between the two curves it's not. Although it's statistically significant, how do we make it better in terms of separation and find who is actually protected against CMV CMI? And the reason that we were looking at this specific aspect is to define a population of patients who potentially would benefit from not getting extended duration late CMV or late extended duration low-term prophylaxis. And what we saw is that when you actually measure CMV CMI and consider other clinical and transplantation factors, including stem cell source, that the curves actually improve and the separation of the curves improves. So that all that to say that CMV CMI is only just a piece of the puzzle. And looking at some of these other risk factors is potentially also important in addition. And those that broke through with late clinically significant CMV infection, despite having high CMV CMI, were largely driven by changes in immunosuppression kind of late post-transplantation, so that it makes sense. So that also it begs the question of whether or not serial testing of CMV cell-mediated immunity may be kind of the way to go, assuming that immunity after transplantation is dynamic, especially in the face of changes in immunosuppression. So some conclusions kind of moving forward. CMV seropositive patients after transplantation are at highest risk for CMV, and the risk is modulated by various factors, including immunosuppression. Low-term prophylaxis decreases clinically significant CMV infection through day 100, but also up to 200 days in patients with extended duration. Maribavir is recommended for the treatment of resistant and refractory CMV infection and disease, but it's not currently recommended as first line for preemptive therapy after transplantation. The CMV incidence after CAR T-cell therapy is approximately 20 to 30%, but the overall disease is rare. Surveillance can be considered in higher risk CAR T-cell therapy recipients, including those that receive steroids. But right as it stands, we do not recommend prophylaxis in these patients. Pre-transplant CMV infection and disease is associated with post-transplant CMV infection and disease, as I mentioned, based off of our study, and the risk is improved following clearance of that CMV prior to transplant. And again, it seems to be that increased pre-transplant CMV serologic titers are associated with an increased risk of post-transplant CMV infection. And lastly, CMV cell-mediated immunity may be helpful in the prediction of late clinically significant CMV infection after transplant, and that prediction may be improved when considering other factors. So it takes a village. Obviously, these are a number of people I'd like to thank, but I'd like to thank you and stop there for any questions. Okay, yeah, no worries. Yeah.
Thank you, Dr. Zamora, for an excellent talk. We're going to try to get caught up a little bit, and if you have any questions for Dr. Zamora, we're coming up on a lunch break here shortly, so I just wanted to try to move us on to our keynote speaker. It's a real pleasure and honor to introduce Loriana Hernandez Aldama. Loriana is an Emmy Award-winning journalist, international speaker, 2 times cancer survivor, and author of Becoming the Story, The Power of Prehab, which I intended to pick up promptly.